So this dissemination exercise is just for us to share the findings of the national situational analysis on this problem of maternal mental health disorders in Ghana. So we've done a nationwide study, what we call quantitative survey and qualitative interviews across the the regions of Ghana, and we've made very interesting and fascinating findings which we find instructive, necessary for policy, necessary for influencing policy, as well as practice and community engagement, all the way towards improving the outcome, mental health outcome of pregnant women and women postpartum. So this study has found that the burden of maternal mental health disorder, the commonest is what we call the perinatal depression, is as high as 50.4% in Ghana. It's about almost 10% in the primary district care setting, about 30% the regional level, and then when you get to tertiary, the highest level of care, as high as 50%. I mean 40%. But the recent study from the Upper East found 50%. Now, these point to a picture of a high prevalence of that problem. Unfortunately, over the years, we haven't had the eye to detect these things. Unfortunately, over the years, there hasn't been the national policy where we screen the women so that we can detect them early towards interventions to prevent the adverse outcome of these problems. Fortunately, based on the research we have done, we've realized that the healthcare system of Ghana has already the structures we can fall on. We do the regular pregnancy schools, antenatal classes. So these are opportunities for we, the healthcare people, to talk to the pregnant women, their partners, and their in-laws about the fact that mental health problems during pregnancy and after delivery do exist. There is a medical reason to explain these things. So the situation where majority of places, especially in the rural areas, think these are spiritual problems, and so they will bundle our people to go and put them with the traditional healers, do sacrifices, wear things around them, and calm them, chain them. We need to do away with those because there is a medical reason why these disorders manifest. When a woman is pregnant, what we call the placenta, which is the afterbirth, it produces a great deal of hormones which is supposed to help the woman's mood during the stages of pregnancy. After delivery, when the placenta is delivered, then these hormones that are supposed to support the woman, the levels drop. And so for the woman who has some risk factor, then the disorder begins to manifest. So there's a medical reason why these things happen. So we look out for, this woman is showing these early warning symptoms. So let's pick her, get a clinical psychologist to see her. Somebody's own may be a more severe, we put them on medication, problem solved. Failure to do these, the women go home with this condition. It affects their bonding with the baby. It affects breastfeeding. It affects their relation with their family, their partners, their spouse. They cannot go to work. Unfortunately, 2 out of 10 of them commit suicide. So the structures are there for us to fall on. There is going to be the need for some modification in the healthcare environment so that when the women come, there's a bit of privacy, because the women also mentioned that the lack of privacy, lack of confidentiality when they come to the hospital is part of the reasons why they don't want to come to the hospital when they detect these conditions. So there's some work we have to do at health service to also modify the hospital environment. Some indicate that when we don't allow their partners to join them during labor, when they are going through the pain, that also tips them in some of this depressive mode. So we have presented to the Ghana Health Service, and some changes are going to be made nationally to be able to accommodate partners and family in order that they can be in there to support their spouses during labor and delivery. They are calling for it. Yeah. Yeah, yes, yes. So repeatedly, the women we interview, those who are pregnant, those who have delivered, those who unfortunately have suffered this maternal mental health disorder, are saying that in the course of their labor, majority of the time, especially in the public hospitals, they are left on their own. Yeah, we know the healthcare staff are burdened with the workload, but they are saying, allow my mom, my spouse, or my sibling, or a close trusted friend to be with me during the course of labor. That would give me some form of encouragement and support. And so the health service has taken that on board. We presented it, and the health service is happy to encourage that as some of the little interventions we can begin to do whilst we wait for a national policy ultimately. It is not out of control, but it is something that we shouldn't allow to get worse than it is now. Because in most of the developed countries, the prevalence of the problem is much lower because they have these routine systems in place that they screen all pregnant women, they screen all women after delivery so that you can detect early. Early detection is very key. Great. Yes, so the recommendation is to screen all pregnant women, okay? At the first time they visit the hospital during pregnancy, screen them again in the second trimester, screen them again in the third trimester, screen them again after delivery. The whole point about screening is that so you see the scores. So the score is high. So this woman has become a higher risk for maternal mental health disorder, depression. So we refer to the clinical psychologist early. Uh-huh. We screen first trimester, it was normal score. Second, it has gone up, we refer. Second was normal. Third, it has gone up, we refer. Then those who are the high risk, then we follow them up for longer. Because if we do not do that, then it escalates into more severe problem. Thank you, sir.